Hello, everybody, and welcome to our question lab this evening. We're happy to have you. This evening, we will be covering genetic disorders. We'll be doing genetic disorders today, and next week, we'll be covering hematology and oncology pharmacology. My name is Sean. I've been with RX Coach for a little over a year and a half, working on our RX Coach program, which we will talk about here in just a second. I apologize for a little hiccup here with my slideshow. Let me get it going again for you guys. All right. Working on RX Coach, we'll talk about RX Coach later. That's our new one-on-one tutoring program. And leading today's dissection is one of our RX coaches, Kasia Bornstein. Kasia.
Hey there, thank you, Sean. So, hey everyone, hope y'all are doing well. I'm a fourth-year medical student here in Miami, Florida. And prior to medical school, I graduated from the Tulane University School of Medicine Pharmacology Master's Program. And before that, I worked in EMS as a paramedic and paramedic educator for several years. I've been working as a study coach and tutor with the RX Coach project for 7 months now, working with students one-on-one mainly regarding preparing for Step 1 and Step 2, but also in helping students build content knowledge for school exams and shelves. This is my fourth Q-Lab, and I absolutely love working with y'all to help build confidence and knowledge to tackle these big exams. As Sean said, today we're going to be working on genetic diseases, which is personally a very important topic to me as a person with Gaucher disease. Now, while these are rare, they're real, and especially highly tested on the USMLE. And developing some fluency with these topics may allow you to clinch the diagnosis one day when someone brings their child to your care with an unusual constellation of symptoms. All right, back to you, Sean.
Thank you very much, Kasia, and we're happy that you're here. And I want to introduce some of our other panelists here today. We've got Kate, who you'll meet later when she does our raffle, and one of our other coaches, Mark Heslin. Mark.
Hello, everyone. My name is Mark Heslin. I'm a fourth-year med student at Cooper Medical School in New Jersey. I've been an RX coach now for about a year, helping students mainly with Step 1 and Step 2 CK prep, and I'm happy to answer all your guys' questions.
Excellent. So our panelists are here to answer your questions, and if you look at the GoToWebinar control panel on the right side of your screen, I think you'll see a question box, and if you type your question in there, one of our panelists will do their best to try to answer your questions. So feel free to ask away, and they'll do the best they can. Once again, we will have a raffle at the end of the evening, so make sure you stick around because you must be present to win. And one of you lucky winners will receive free access to RX 360, which will be a great tool for you guys to use while you guys study for your boards and prepare for your exams in med school. Now, you've had a chance to meet us. We want to get to meet you. So I'm going to ask you guys a question. And the question is pretty simple. Who are you? Please take a moment to let us know and familiarize yourself with this poll format, because this is the same format of poll that we will see as we do our 4 question dissections this evening on genetic disorders. We'll give you guys a couple of seconds to respond, and then we will get started with our first question of the evening. I see the responses are coming in slowly, so we'll give you guys a few more seconds. But please take a minute to submit your responses. And I see that responses are coming in. We'll give you guys a couple more seconds here, and then we'll get started with our first of 4 questions this evening on genetic disorders. So let's see here. Looks like we've got a lot of international students. 66% of you guys are international students or graduates. 26% of you guys are US or Canadian-born international medical students or graduates. So we want to welcome all of you guys here this evening. For those of you guys who are attending our question lab for a second or third time or even more, welcome back. And for those of you who are new, thanks for joining us. We do these every Tuesday evening at 6 p.m. Eastern. I know a lot of you guys are studying for Step 1, so we'd like to know, when do you guys plan to take Step 1? We'll give you guys a few seconds to let us know, and this way we can plan events accordingly, knowing when you guys are getting ready to gear up for the big day. Excellent. I see the responses are coming in. We'll give you guys a few more seconds. And if there are any topics you'd like us to cover in future question labs, please let us know in the question box. We'd love to hear from you. All right, let's take a look here and see when you guys are taking your exam. Looks like A lot of you guys are taking it here between now and the end of the year, as well as the early part of 2021. And for those of you who really want to maximize your potential on test day, listen carefully to what we're doing today and learn from our RX coaches, because our coaching program has been really successful for a lot of students. We work with you on a one-on-one basis to identify your strengths and weaknesses, work on your test taking skills, work on timing, work on stamina, and taking that holistic approach and really working on all those areas really helps you maximize your potential, especially as you're approaching test day or gearing up to start studying, or if you're dedicated. So we'll talk about that more in a little bit. But without any further ado, let's go ahead and get into our first question of the evening. Now, as you guys can see, the answer choices are not there, and that is by design. The first step in our RX coach methodology is to cover up the answer choices. And the reason we do that is because we don't want the answer choices to dictate or guide your thought process. And we don't want you guys to see an answer choice that you're unfamiliar with, and that may cause you to panic on test day or while you're trying to take your exam. So we've covered those answer choices up. And after we do that, we will read the lead-in or the question itself. The lead-in is always the last sentence. So here we go. Which of the following organelles is the location at which the dysfunctional enzyme in this neonate's disorder normally acts to phosphorylate proteins? Once again, which of the following organelles is the location at which the dysfunctional enzyme in this neonate's disorder normally acts to phosphorylate proteins? And once we read the lead-in, we'd like to ask our students, how many steps does this question require? So let me give you some examples. An example of a one-step question could be where they ask you for a diagnosis. An example of a two-step question could be where they ask you what is the treatment for a diagnosis. And an example of a three-step question could be where they ask you what is the mechanism of action for a treatment for a diagnosis. So with those examples in mind, please let us know in the question box how many steps you think this question will require. We'll give you guys a few seconds to respond, then we will continue with the question. I see you guys are submitting your responses here, and I see a lot of people saying 2 steps, 3 steps. Excellent. So Kasha will go over that as we do this question together. So with that being said, let's go ahead and read the question. Now, normally in our coaching sessions, we'll stop you after every sentence, ask you what's important, what you want to highlight, what you're thinking, what's on your list of differentials, to really know how you think and how you apply what you know. Now, we can't do that with all of you individually, so I will pause briefly after each sentence to give you guys a second to gather your thoughts. So here we go. A 17-year-old female immigrant from Haiti who was pregnant for the first time presents to the emergency department in active labor. She is fully dilated and effaced with contractions occurring every 2 to 3 minutes. She has not received any prenatal care and estimates that she is at 38 weeks according to the date of her last menstrual period. 45 minutes later, a boy is delivered vaginally without complications. The neonate's APGAR scores at 1 minute and 5 minutes are 7 and 9 respectively. However, the pediatric team notices that both of the infant's hips are dislocated. The bilateral shoulder and elbow joints appear to be restricted in movement. The corneas appear cloudy bilaterally. And the infant's head is bulging, with the anterior aspect larger than the posterior. His nose appears short and flat, and his neck veins appear to be bulging. Which of the following organelles is the location at which the dysfunctional enzyme in this neonate's disorder normally acts to phosphorylate proteins? Kasha.
All right, thank you, Sean. So as Sean mentioned, we recommend several different strategies and techniques to ensure that students can go about answering questions in a systematic fashion. The approach we'll be focusing on here helps you ensure you're actually understanding the question you're being asked, and also identify where content gaps are so you can focus your studying on that material. So let's go ahead and review the answer choices. Now, when we talk about answer choices and going over them, we like to start at the bottom. The reason we do this is because we don't want to become biased by something you see early on. And working your way up from the bottom ensures that you're going to get through all of the answer choices. So we're going to go ahead and do that now. So E, proteasome. D, lysosomes. C, Golgi apparatus. B, extracellular space. Or A, endosomes. All right, so go ahead. We'll give everyone a moment to think about their answer choice, take a look, and Sean is going to open up the poll.
Excellent, and we'll give you guys a moment to respond here. I see a lot of you guys typing in the name of the disease. Well, that's not what this question is asking, right? So we need to know that before we answer the question. But for those of you who got it correct, great job so far. But let's see if we can't go the extra step and answer the question that this test writer is asking us. So we'll give you guys a few more seconds to respond. I see a lot of you guys are on the right track. If you guys are unsure, please take your best guess, and we're going to go over the correct and incorrect answer choices here in just a moment. All right, I see the responses are coming in. We'll give you guys a few more seconds, and then we'll take a look and see how you guys did. Looks like 46% of you guys, so answer choice, the most common answer choice was lysosomes. And in second place with 45% of you guys, this is pretty close, was C, Golgi apparatus. So let's see what the correct answer is. And the correct answer is C, Golgi apparatus, and 45% of you guys got that right. So well done to all of you. For those of you who didn't get it right, don't worry, just pay attention to Kasha right now, and you'll be able to get it right on test day. Kasha.
All right, thank you, Sean. So I think Sean made a really good point that I'd like to emphasize, which is that this is a, maybe a 2 or possibly 3-step question. And, the important thing here is if we think about what kind of question this is, we have to identify the disorder, which many already identified in the question box. And then more importantly, we need to identify the pathophysiology present in this disorder. In this case, the dysfunctional enzyme that usually phosphorylates enzymes. And then potentially as there's a 3-step question, finally, in which organelle the process usually occurs in. Now this can be a tough question, but one clue is given here in the lead-in. They pretty much tell us that we can anticipate organelle enzyme dysfunction, suggesting there is some genetic disease at play. So let's go through and pick out the pertinent information that we need to identify why the answer choice, Golgi apparatus, was the correct answer here. So this vignette describes a neonate born to a 17-year-old woman without any prenatal care, which is often a setup for a question about unanticipated genetic diseases. This kiddo is born in some distress with a mildly low initial APGAR score, but is quickly resuscitated. Several concerning phenotypic findings are noted: hip dislocation, restricted movement, cataracts, corneal clouding, and craniofacial abnormalities, all suggestive of a particular disease, which is eye cell disease, also commonly called mucolipidosis type 2. Now, the cataracts are important in particular, as there's a short but important list of diseases that involve cataracts early in life. Can you go ahead and write in the chat box what neonatal or infant diseases present with congenital cataracts? So go ahead and feel free to write that in. All right, I'm seeing Hurler syndrome, rubella. Any others that y'all can think of? Galactosemia, very important. Okay, good. So galactosemia.
Somebody mentioning hunters, so keep that in mind.
Yeah, awesome. Okay, so, we have a very good differential here. So galactokinase deficiency, galactosemia, rubella, trisomies, mucolipidosis, and mucopolysaccharidosis, which is Hurler disease. So this is an important list to consider anytime you see congenital cataracts. So good, I'm seeing aldolase B deficiency, which is classic galactosemia. So good. So to understand eye-cell disease, it's critical to identify the role of the Golgi apparatus in normal cell trafficking. The Golgi acts as the distribution center where it receives proteins and lipids from the endoplasmic reticulum, and then based on the modifications that occur in the Golgi, sends those proteins and lipids to vesicles in the plasma membrane. Mannose 6-phosphate, that's a really important one to keep in mind, is a tagging protein that's used to modify these lipids and other proteins that occurs in the Golgi, and is important for sending proteins to lysosomes. Without this tag, proteins are incorrectly sent to the extracellular space, and aberrant accumulation of undigested proteins and glycans in the lysosomes causes the clinical manifestations of this disease. Other classic findings expected in patients with eye-cell disease include psychomotor impairment, hepatosplenomegaly, and unusually thick or tight skin in certain parts of the body. Because of the central role that the Golgi has in directing proteins and lipids to be broken down in the lysosome, I often think of eye-cell disease as involving features of several different lysosomal storage disorders, but not fitting neatly into any other LSD diagnosis, like Gaucher disease, or the similarly named but very different mucopolysaccharidoses, Hunter and Hurler syndromes. Importantly, whereas lysosomal storage disorders involve cellular material accumulating in the lysosome where defective lysosomal enzymes are unable to break them down, in eye-cell disease, the lysosomal enzymes are sent out of the cell and found in high quantities in the blood. Okay, so that's eye-cell disease. Very important and a high-yield genetic disease to be aware of and be able to differentiate on test day. Let's talk about why the other answer choices are incorrect. E. So the proteasome is an important non-membrane bound organelle that degrades damaged or ubiquitin tagged proteins. Dysfunction of the ubiquitin proteasome system is implicated in several different diseases, including Parkinson, which presents later in life with a resting tremor, cogwheel rigidity, bradykinesia, and a shuffling gait. Given this patient's young age and constellation of symptoms, the proteasome is not at fault here. So we'll take a look at lysosomes. And that's a very, very important one to think about because lysosomes play an integral role in cell trafficking and degradation of proteins and glycans. And there is some dysfunction in terms of the relationship of lysosomes in eye-cell disease. Several lysosomal storage diseases are caused by a deficiency in one or more of the lysosomal enzymes, leading to accumulation of abnormal metabolic products. Examples of these diseases include Tay-Sachs, Fabry, metachromatic leukodystrophy, Crab disease, Gaucher disease, Niemann-Pick, Hurler, and Hunter syndromes. Although these disorders can cause some symptoms similar to those seen in the patient, such as corneal clouding or skeletal abnormalities, none are associated with all of the symptoms seen in this patient. All right, so we'll move past C because that's the correct answer and go to B, the extracellular space. So that's the destination to which abnormally tagged proteins are sent and is also the location of further processing of other proteins such as procollagen. Dysfunction of the proteolytic processing or cross-linking of procollagen molecules in the extracellular space can lead to Ehlers-Danlos, which is characterized by hyperextensible skin, increased risk of bleeding, and hypermobile joints. Although patients with Ehlers-Danlos syndrome might present with bilateral hip dislocation, they wouldn't be expected to have the other symptoms observed in this patient, which we saw: restricted joint movement, a bulging scaphocephalic head with a flat, short nose, and bulging neck veins, and very importantly, corneal clouding, congenital cataracts. And lastly, we'll look at answer choice A, endosomes. So endosomes are vesicles that have taken up extracellular debris by budding off of the cellular membrane into the cell. Though through maturation and fusion with other vesicles, endosomes ultimately become lysosomes. endosome and lysosome dysfunction is thought to potentially play a role in both formation and degradation of the amyloid fibrils in Alzheimer's disease, but that's not the diseases at play here. All right, so nice work, everyone. Definitely good differential, and important to differentiate lysosomal storage disorders from the dysfunction going on in eye cell disease. Let's move on to question 2. Back to you, Sean.
Excellent. Thank you, Kasha. So well done, everybody. 45% of you guys got that question right, which is great. For those of you who didn't, hopefully that explanation helped. And remember, when you guys are reviewing your questions, to go over the incorrect and correct answer, just like we did, because we want to make sure you got it right for the right reasons, and also learn from that question and know what the other answer choices are or alluding to. So great job, everybody. Let's move on to our second question of the evening. Once again, as you guys can see, the answer choices are covered up, and that is by design. Like I said before, we do that because we want to make sure that the answer choices do not dictate or guide your thought process. And so that if you see an answer choice you aren't familiar with, you don't end up panicking, and then as a result of that anxiety, end up missing the question as well. So we've covered those up for you, and then we will read the lead-in together. So here we go. Which of the following is expected to increase in this patient? Which of the following is expected to increase in this patient? I'll give you guys a couple of seconds to let us know in the question box how many steps you think this question will require, and we will go ahead and read the rest of the question. Wonderful. I see some responses coming in, and as always, Kasha will go over how many steps this will require when he goes over the question with you guys here in just a second. So here we go. A 4-year-old male is brought to his pediatrician by his parents due to poor feeding, vomiting, bizarre movement, and sweet-smelling diapers. The patient was born via normal spontaneous vaginal birth at full term. There were no complications with the pregnancy or delivery. The parents declined immunizations and genetic testing. The patient has been breastfed exclusively and is receiving vitamin D supplementation. Family history is unremarkable, except for an uncle who passed away as an infant from an unknown disorder. Temperature is 36.3 Celsius or 97.5 Fahrenheit. Pulse is 124, and respiratory rate is 33. On physical examination, the patient appears irritable and has stiff limbs. Which of the following is expected to be increased in this patient? Kasha.
All right, thank you, Sean. So let's talk again about how many steps this question should be, because we want to maintain focus on what aspects of the vignette we need to pay most attention to. In the last question, we saw that while eye cell disease was definitely the disease in question, that wasn't what the question was asking about, right? So this, again, is likely a 2 or maybe a 3-step question in which we need to identify what the disease is, and then what we might anticipate is elevated as a result. So let's go ahead with those answer choices. And once again, we'll start at the bottom and work our way up. So starting with E, propionic acid. D, phenylalanine. C, leucine. B, fructose. Or A, ammonia. So which of these is expected to be increased in this patient?
Excellent. We'll give you guys a few seconds to respond. You know, we do the steps and we ask you how many steps it requires because we want to make sure that you have an organized thought process and you answer the correct question, because oftentimes students know what the disease is and then end up answering the wrong question or end up getting distracted by the fact they know or do not know something. And so it's important on test day to really organize your thought process like we're doing here so that you can be consistent with your questions, have a consistent approach, and really maximize your potential and not fall for any traps that the test writer may set out for you. We'll give you guys a few more seconds to respond, and then we will go over the correct and incorrect answers. Wonderful. Let's see how you guys did. Looks like 58% of you guys picked leucine, and in second place was phenylalanine, with 23% of you guys picking answer choice D. Let's see what the correct answer is. And the correct answer is leucine. So well done, everybody. 58% of you guys got that question right. I'll turn it back over to Kasha so you can explain the correct and incorrect answer choices. Kasha.
All right, nice work, everybody. So I see a lot of folks got this question right, and very nice work. And for everybody else, we're going to spend some time understanding what we missed here. So let's go through this question one more time and identify the pertinent details in this vignette. This is a 4-day-old boy with poor feeding, vomiting, bizarre movements, and sweet-smelling diapers, with, again, no prenatal testing. Family history yields an uncle who died as an infant, which is a clue suggesting an underlying genetic disease that may also be present here. Vitals look okay for a neonate, though the infant is irritable and has stiff limbs. This constellation of symptoms is important, and there's only a short list of diseases that the USMLE Step 1 wants you to be able to identify from the smell of an infant's urine. So if I were to tell you that this kiddo had musty or mousy smelling urine, what would you think of? Go ahead and put that in the chat box. Okay, I'm seeing PKU, or phenylketonuria, so very important. So yeah, there's a pretty short list, and it's really maple syrup urine disease and PKU that USMLE question writers want you to be able to identify just from the smell of an infant's urine. So that will often be a part of that question vignette. So maple syrup urine disease is an autosomal recessive disease with decreased or absent branch chain alpha keto acid dehydrogenase complex. When this enzyme is deficient, there's decreased decarboxylation of the branch chain amino acids, isoleucine, leucine, and valine. And a very useful mnemonic here is I love Vermont for isoleucine, leucine, and valine. So I love Vermont maple syrup. Okay, so with decreased decarboxylation of the branch chain amino acids, alpha keto acids thus build up in the serum and ultimately spill over into the urine, giving you your sign of that sweet smelling urine. This condition typically manifests early in life, usually within a few days of birth. It presents with vomiting, poor feeding, hypertonia, sometimes hypotonia, and that sweet smelling urine. If the disease is not managed adequately, it can eventually lead to central nervous system defects, intellectual disability, and eventually even death, as the increased alpha keto acids are very neurotoxic, especially leucine. So diagnosis of MSUD is typically done via genetic screening at birth, which these parents declined. Treatment consists of restricting isoleucine, leucine, and valine in the diet, which is essentially a protein-restricted diet. Patients should also supplement their diet with thiamine, as it's a coenzyme of branch-chain alpha keto acid dehydrogenase. So those are some really important kind of next step questions that oftentimes at this point, the question writers expect that many of us will know the answer to a question about maple syrup urine disease and want us to know an additional step, which is how would you treat it, or what might you expect as a result of the treatment. So good. Great work, everyone. Definitely a high yield concept for USMLE exams. Let's go through each of the other answer choices, identify what may have been some of the other thoughts here. So starting with E, propionic acid. Increased propionic acid is the expected finding in propionic acidemia, and that would present with hypotonia and acidosis rather than the stiff limbs seen in this patient. Additionally, we would also expect to see a very rapid respiratory rate to breathe off that increased acidosis, and we don't see that in this patient. We'll go to D, phenylalanine, which many of the astute observers in the audience today noted would be identified by a musty body odor or a mousy smell of the urine. And phenylalanine would be expected to build up in phenylketonuria, which has an autosomal recessive inheritance. So in phenylketonuria, patients have that, as noted, musty body odor, intellectual disability, and albinism due to decreased phenylalanine hydroxylase. These do not match the symptoms seen in this patient. So we'll go on to B, fructose, which would be seen building up in disorders of fructose metabolism. These autosomal recessive disorders only become apparent once foods with fructose are introduced into the diet. So a high yield point is that you might keep these on your differential if they were telling you about a 6-month-old with hypoglycemia, jaundice, cirrhosis, and vomiting. And you wouldn't expect this before the onset of any kind of fructose containing food source in the diet. So that would be something like juice or honey. Fructose is not present in breast milk, which the question vignette notes that this patient is receiving. Okay, and lastly, we'll look at ammonia. A buildup of ammonia would be expected in urea cycle enzyme deficiencies, such as ornithine transcarbamylase deficiency, arginase deficiency, carbamoyl phosphate synthetase deficiency, and ornithine transcarbamylase deficiency. So type 1 or type 2. So OTC deficiency involves lethargy and poor feeding, poorly controlled body temperature, and high respiratory rates. And these patients may experience seizures as well. While this child does have poor feeding, none of these vital sign disturbances would be noted or are noted. And OTC deficiency does not account for the patient's sweet-smelling urine. Okay, so very important to know maple syrup urine disease and differentiate it from other genetic diseases on test day. Nice work, everyone. Back to you, Sean.
Excellent. Thank you, Cautious. A great job, everybody, with the questions so far. We made it a point to pick out some high-yield genetic disorders for you guys today, and I see you guys are doing really well with them. For those of you guys who might be struggling in a class or studying or struggling while you're studying for your board exams, you know, I really recommend you guys look into RX Coach. A lot of students, you know, they fail to realize that everybody is so unique, right? You have so many people in your class, but everybody learns differently. Everybody thinks differently, and everybody applies what they know differently. And although there are a lot of USMLE programs out there that, you know, make you sit in a classroom or live online for 6, 8, or 10 hours, they really don't tackle the individual elements that will help you become a better student and test taker. And they hardly ever address test taking issues. And by doing practice questions and dissections on certain topics and giving you a study plan, we're able to see how you think, and then we're able to tailor these study plans to you and really work with you on a one-on-one basis to help you maximize your potential on test day and even on your board exams and in school exams. For example, we've had students come to us and say, hey, you know, I've got block exams coming up. I need help. I haven't been doing that well. I feel like I'm a little behind. We've got you covered. We're here to help you while you're in school and while you're preparing for your board exam for step 1 and step 2. And that individual approach really is an efficient way to study, because a lot of students spend a lot of time trying to figure out what they should be doing and trying to stay organized and trying to figure out why they're not progressing if they're not progressing, or why they've plateaued. And we can help you with one of our expert coaches identify all that and make your studying more efficient so that you can save time while you maximize your potential. And as you guys can see here, we have a wonderful testimonial from one of our students who had a 73-point increase. And that isn't even the largest increase we've seen. We've had students that have graduated 10, 12, 13 years ago that have come to us and passed their exam when they've been unsuccessful multiple times in the past. We motivate you, we hold you accountable, and we teach you in a way that makes sense for you by keeping in mind your individual strengths, weaknesses, and thought process. So if you're interested in receiving that one-on-one attention and maximizing your potential, please do visit us at rx-coach.com. That's rx-coach.com, and schedule a free consultation to discuss the program and how it can benefit you. If you guys want some general study advice, a free study planner, we have that available too at firstaidteam.com. But if you want to talk about coaching and how you can benefit from it, like so many others have, and you want to be one of our success stories, schedule that free consult at rx-coach.com. We only accept a limited amount of students at a time because, you know, we don't want to strain our tutors. We want to maintain quality. So the sooner you register, the better off you will be. So with that being said, let's go ahead and get into our third question of the evening. Once again, the answer choices are covered up, and we will start with the lead-in. What is the most likely cause of this patient's condition? What is the most likely cause of this patient's condition? I'll give you guys a second to let us know how many steps you think this question will require in the question box, and then we'll proceed with the rest of the question. Excellent. I see a lot of you guys are responding. So let's go ahead and read the question. Parents of a 3-week-old boy bring him to his pediatrician to undergo circumcision. The parents express concern because he bruises easily. The pediatrician finds small areas of ecchymosis over the buttocks and lower extremities. He decides to proceed with the circumcision and completes it without complications. 10 minutes after the procedure, bleeding from the penile foreskin has not stopped. Laboratory tests, including a peripheral blood smear, show the following: hemoglobin of 15, platelets of 60,000, PT or prothrombin time of 13 seconds, and a PTT or partial thromboplastin time of 35 seconds. And ristocetin cofactor assay says no platelet aggregation observed. And I'll give you guys a second to take a look at that image. And now we will read the lead-in again. What is the most likely cause of this patient's condition? Kasha.
All right, thank you, Sean. So again, let's figure out how many steps this question requires. This question is asking us, what is the most likely cause of the patient's condition? Which is usually either a 1-step, what's the diagnosis, or a 2-step, identify the underlying pathology of this diagnosis question. One thing I often share with my students is that you may not recall the name of a disease, but recognize what is being described. So if you've already identified the question as having 2 steps, you won't need to sit there puzzling over trying to remember the name. It's not what the question is asking you to do. And you can use the time you save wisely. So let's take a look at these answer choices. Starting with E, GP1B receptor deficiency. D, GP2B/3A deficiency. C, factor V mutation. B, factor IX deficiency. Or A, ADAMTS13 deficiency. So once again, we'll give everyone a few moments to think through this question and the answer choices. Go ahead and select the answer choice you think is correct, and we'll come back together to discuss.
Excellent. Thank you, Kasha. So here we go again, our third question of the evening. We've been doing well so far. A lot of you guys have been getting our questions right. So let's keep that trend going. Let's keep the momentum going and do well with this one also. I'll give you guys a couple more seconds to respond. As always, we do have a raffle at the end that Kate is going to conduct. So make sure you stick around because you must be present to win. I'd hate for you to win a prize and then not be here to collect, right? All right, I'll give you guys a few more seconds here to respond, and then we will go over the correct and incorrect answer choices. All right, looks like a lot of you have responded. We'll give you guys a few more seconds here. Excellent, and let's see what you guys picked. In first place with 35% was GP2B3A deficiency, and in second place with 26% of you guys picking was answer choice E, GP1B receptor deficiency. So let's take a look and see what the correct answer is. And the correct answer is E, GP1B receptor deficiency, and 26% of you guys got that right, so well done. For those of you who didn't, don't worry, Kasha's gonna explain it to you right now. Kasha.
Okay, so nice work. This is definitely a tough question. So we can see that this question is asking us to describe the underlying pathology at play in the diagnosis. Let's take a look at the vignette to see what the pertinent details are. So this question describes a 3-week-old kiddo who presents with easy bruising and ecchymoses and presents for circumcision. Following the procedure, he's still bleeding. Lab tests are significant for a normal hemoglobin, thrombocytopenia, a normal PT and PTT, and a ristocetin cofactor assay showing no platelet aggregation. Now, ristocetin is a molecule that causes von Willebrand factor to bind the platelet receptor glycoprotein 1b, or GP1b. So when ristocetin is added to normal blood, it causes agglutination of fixed platelets. Absent aggregation indicates there is a problem with either von Willebrand factor or the platelet receptor. Now, if you don't recall how to use the ristocetin cofactor assay, that's okay. You can actually answer this question without it. So in this case, the disorder at play is Bernard-Soulier syndrome. How can we identify that? Well, for one, this question stem told us there's a prolonged bleeding time of 10 minutes. They snuck it right in there talking about how this kid was still bleeding after 10 minutes. And we can see that there's no other bleeding problem as the PT and PTT are normal. These together suggest a platelet problem rather than a factor deficiency in which PT and or PTT can be elevated. In addition, this question gives you a histology picture showing you giant platelets, which oftentimes people remember as big suckers, or BS for Bernard-Soulier, which, if you can identify what you're looking at, clinches the diagnosis right there and then. You can see in the corner, there is a small platelet, a normal sized platelet, right in the upper left-hand corner of the histology slide. And that's a normal platelet. So this is a really, really huge platelet. So what's going on in Bernard-Soulier? Bernard-Soulier disease is a rare autosomal recessive inherited deficiency of the platelet membrane protein complex, GP1B, which is the von Willebrand factor receptor. Binding between GP1B and von Willebrand factor allows for normal platelet adhesion to the subendothelial matrix after vascular injury. And deficiency leads to reduced platelet adhesion. Morphologically, the megakaryocytes, which eventually become platelets, have an abnormality in what's called the demarcation membrane system, basically how those platelets separate away from the megakaryocyte, which likely explains the large platelets and the thrombocytopenia. Okay. So that makes answer choice E the correct answer here. Let's discuss the answer choices, the other answer choices, excuse me. Starting with answer choice D, GP2B/3A deficiency. So a deficiency of the GP2B/3A, it's a real mouthful, receptor results in a disease called Glanzmann thrombasthenia. And these two diseases are often put in answer choice options to consider against one another. GP2B/3A normally functions as a receptor for fibrinogen, not von Willebrand factor. So its deficiency does lead to impaired platelet aggregation. Although easy bleeding and bruising can be seen in this condition, the platelet count is usually normal, unlike the patient in this vignette. And that's due to the additional role that GP1B plays in that demarcation membrane system in megakaryocytes. Additionally, the ristocetin assay in Glanzmann thrombasthenia would show agglutination, where there was no agglutination seen in the patient in the vignette. Okay, so that's answer choice D. Let's move on to answer choice C, which is factor V or factor V Leiden. And factor V Leiden is caused by an autosomal dominant mutation in factor V. The mutation results in a change of a cleavage site on factor V, rendering it unable to be inactivated by the anticoagulant protein C. Factor V Leiden is the most common inherited cause of hypercoagulability and can present with recurrent thromboses beginning at a young age. So you would think this would be a high yield or high differential for somebody who's showing up at early age in their 20s or 30s with an unexplained DVT or pulmonary embolism. Agglutination with the ristocetin assay will be seen in factor V Leiden. And however, this patient has signs of bleeding susceptibility, so totally opposite problem. And no agglutination would be seen, or no agglutination was seen, with the ristocetin assay. All right, so now we'll look at factor IX deficiency, which is hemophilia B. And that's a rare genetic disorder that causes a prolonged PTT, or partial thromboplastin time. Like hemophilia A, which is far more common, hemophilia B is X-linked, recessive, and this patient's PTT was normal, making this diagnosis unlikely. All right, and finally, ADAM TS13 deficiency. So decrease in the function of the enzyme ADAM TS13 leads to thrombotic thrombocytopenic purpura, or TTP. Now, TTP presents with the pentad of fever, microangiopathic hemolytic anemia, thrombocytopenia, renal dysfunction, and neurologic abnormalities. And people often remember that as fat RN. Now, for F is for fever, A is for anemia, T is for thrombocytopenia, R is for renal dysfunction, and N is for neurologic abnormalities. Although TTP can present with thrombocytopenia and a normal PTT and PTT as seen in this patient, a peripheral blood smear, which they gave us, would show schistocytes, not these giant platelets or big suckers. Okay, so definitely a tougher question, but knowing how to use these coagulation studies can make these questions much more straightforward. Back to you, Sean. Nice work, everybody.
Excellent. Great job, everybody. I know that was a little bit of a challenging question, but you're going to have those on test day, right? You're going to have a lot of challenging questions. And if you can't wrap your head around how to handle those, if you're weak in a certain area, whether it's content or knowledge related or test taking skills, like I said, we have our coaching program for that reason, to help give you the individualized approach to identify why you're missing questions and then rectify it before you take your test. So once again, if you want that one-on-one help, visit us at rx-coach.com and schedule that free consultation so we can talk about the program and how it can benefit you. And I see a lot of coaching students here today, so welcome to all of you. With that, let's go ahead and get into our last question of the evening. Once again, next week we'll be conducting a webinar on Heme-Onc Farm, and make sure you stick around until the end so we can do that raffle, and maybe you will be our lucky winner. Once again, the answer choices are removed, and we will begin with the lead-in. Which of the following describes the mechanism involved in this patient's skin condition? Which of the following describes the mechanism involved in this patient's skin condition? And I'll give you guys a second to respond in the question box and let us know how many steps you think this question will require. Wonderful. I see your responses coming in. A lot of the responses are coming from people who I see on webinars and question labs every single week, and we're happy you guys are here. And we're happy you guys are learning from these sessions that we conduct. Let's go ahead and read the question. A 4-year-old boy is brought to the emergency department by his mother because he has had pain in his right knee for 2 days. His mother mentions that the boy had a fall 5 days ago. His mother also mentions that he has a history of easy bruising, tingling in the limbs, and recurrent skin and respiratory infections. She is not currently giving him any medication. The patient's temperature is 38.3 Celsius or 101 Fahrenheit. On physical examination, his right knee is found to be warm and tender on palpation. He has pale skin and blonde hair. Which of the following describes the mechanism involved in this patient's skin condition? Kasha.
All right, thank you, Sean. So as always, we're going to start the final question by trying to figure out how many steps there are. First, we're going to need to identify what this condition is that the patient is experiencing, and additionally, the underlying physiology producing this condition. This is a classic two-step question. So let's take a look at these answer choices. Starting with E, tyrosinase deficiency. D, phenylalanine hydroxylase deficiency. C, mutation of the X chromosome. B, microtubule dysfunction. Or A, autoimmune destruction of melanocytes. So go ahead, we'll give everyone a minute or two to go over this and select their answer.
Wonderful, thank you, Kasha. So it's our last question of the evening. Let's try to finish strong. We'll give you guys a few seconds to respond here, and then we'll go over the correct and incorrect answer choices. I see a lot of responses are coming in. We'll give you guys a few more seconds here. Once again, if you aren't sure what the answer is, take your best guess. Remember, on your board exam, you should never leave a question empty because there is no penalty for guessing. So if you're unsure what the answer is, just take your best guess. Never leave a question blank. And there's certainly not a penalty here tonight, so just take your best shot. Looks like a lot of you guys have responded. Let's see how you guys did. In first place, with 41%, was microtubule dysfunction, and in second place, with 26%, was tyrosinase deficiency. So let's take a look here and see what the correct answer is. And the correct answer is B, microtubule dysfunction, and 41% of you guys got it right. So well done, everybody. And let's have Kasha explain it to us. Kasha.
All right, thank you, Sean. So this patient presents to the emergency department with knee pain for 2 days, a fever, and a swollen tender knee, all signs and symptoms suggestive of a septic joint. Importantly, he has a history of easy bruising, tingling in the limbs, and recurrent skin and respiratory infections, suggesting a possible immune deficiency problem. Lastly, he has pale skin and blonde hair, which if you can pick up on in the context of an immune deficiency, just about gives this disorder away. So with these findings, you should be highly suspicious for Chidiac-Higashi syndrome. Chidiac-Higashi syndrome is an inherited autosomal recessive condition characterized by abnormal cellular trafficking. A defect in the LYST or LYST gene leads to microtubule dysfunction in phagosome and lysosome fusion. Chidiac-Higashi syndrome presents with progressive neurodegeneration, lymphohistiocytosis, albinism, pyogenic infections, and peripheral neuropathy. A peripheral blood smear obtained from a patient with Chidiac-Higashi will show giant granules in platelets and granulocytes. Other lab test results may include pancytopenia and coagulation defects. So, why the albinism? Albinism is defined as a hereditary condition in which the melanin synthesis pathway is affected, resulting in hypopigmentation. Partial albinism is a result of the failure of melanocytes to transport pigment-containing melanosomes to surrounding keratinocytes in the epithelium. All of the features of Chidiac-Higashi syndrome come down to the inability to get cellular features where they need to go, blocking nerve conduction, melanin production, and causing immune dysfunction. Okay, so that's really important, that triad right there. So, and again, just to comment, this is maybe a two-step question in which the first step, if you could identify just the name of the disorder, wouldn't necessarily give you the right answer here, right? You have to go one step further and identify that it's microtubule dysfunction is what's going on here. So let's go ahead and take a look at why these other answer options were incorrect. Starting with E, tyrosinase deficiency, which leads to albinism, but this patient's other symptoms, such as recurrent infections, would not be present. So we know that albinism is pale skin, often blonde hair and blue eyes, and is associated with an increased risk of developing skin cancers, but not recurrent infections. D, phenylalanine hydroxylase deficiency, which we discussed in the description for question 1 answer choices, which presents with intellectual disability, seizures, and that musty body odor, along with decreased skin pigmentation due to decreased production of melanin, as tyrosine cannot be made from phenylalanine, and melanin is made from tyrosine. Aside from decreased skin pigmentation, this patient's not experiencing any of those other symptoms, so another mechanism is more likely. C, mutation of the X chromosome, which leads to Fragile X syndrome. Now, individuals with Fragile X syndrome have a constellation of microcephaly, macroorchidism, and long faces, and none of which are seen in this patient. There's no increase in recurrent infections in Fragile X. And finally, A, autoimmune destruction of melanocytes. So that would lead to vitiligo, which presents as irregular areas of complete depigmentation, which are not seen in this patient with global, right? That's global albinism, pale skin, and blonde hair. Autoimmune destruction of melanocytes also does not lead to recurrent infections. So, a tough question, but make sure you go that one step further to not just identify the disease, but what the underlying mechanism of that disease is, what the pathophysiology is. So that's it from me. Great work, everybody. Pleasure working with you as always. Back to you, Sean.
Thank you, Kasha, and great job as always. This question is a great example of how if you don't pick up on all of the clues, you're going to pick the wrong answer. So some of you guys picked up on the pale skin and selected tyrosinase deficiency, but you guys didn't pick up on the other clues. And that's a test-taking skill that we're happy to teach you, because not every clue is important. Some are there to distract you, and it's important to know the difference. So for those of you guys studying, I do want to point out something to you guys that I have found extremely helpful, and I think you will as well. And I'm referring to, of course, our RX brick. So for those of you guys who haven't taken a look at bricks, I highly encourage you to do that. Here's a brick on cell signaling. As you can see here, we've got learning objectives laid out, little clinical correlations for you as well as they come up to help you relate this to the clinical things. Wonderful learning modules that go over the content, have nice graphics in them as well. Flashcards to help you retain and practice that information. And as you continue to learn the material, you will see other clinical correlations as they come up, and of course, more flashcards. And as you get to the end, you're going to see a summary of key points that we want you to learn from each brick. Once you get to the bottom, you're going to see practice questions. And once you get the answer right, you will see an explanation of why it's right. And then, of course, you can mark off these learning objectives and see which ones you're confident with. And then if you want to go deeper, you can. You can go directly into first aid. You can go into flash facts and practice and study with our flashcard system, which uses spaced repetition to help you see things that you're weaker in more frequently to help you strengthen that foundation. We've got express videos there, as well as COMLEX questions that you can practice with. And that's one of the things I found most helpful, is because oftentimes we have so many resources, it's hard to kind of flip back and forth and keep everything organized. But when you use a brick, everything stays organized. If you have RX 360, you have digital first aid, which really helps you do the same thing. You can go directly into other resources to elaborate or get explanations or practice what you've just learned.